All right, we are live.
All right, good morning, everyone. Welcome to the joint meeting with Senate Health and Welfare and House Healthcare. It is Thursday, May 14th. Seems like we're moving along pretty quickly, but too much to do in a short period of time, I'm sure. So today we're continuing our discussion on the telehealth store and forward bill, and we've asked Department of Financial Regulation and DVA to come in and offer some testimony about a possible working group related to telephone coverage going forward after as the emergency extends on, and then after the emergency. So we do have a bill on our calendar. We do have a bill somewhere. Jen, is that bill up on our page for today?
I think so. I sent it to Nellie to repost. If not, it's posted on last Thursday.
Okay.
Under my name.
All right. So
And I just want to remind you, it has two pieces to it. One of them is moving up the effective date for the store and forward. And that's the part in particular, I think, that DVA wants to speak to.
Right.
And the other is the DFR working group, which would on telephone coverage going forward. And that would also include DVA as a participant.
Okay. So why don't we just move right ahead into our testimony? Sebastian Arduengo is here and Nissa James is here. Good morning. Thank you both for being patient as we were getting organized. Either one of you can go first. I have Sebastian first up, but I see Nissa is visible. So did you two do you have a preference for who goes first?
DVA would be happy to go first if that would be acceptable to the Department of Financial Regulation.
I am more than happy to let DVA go first this morning.
All right.
Wonderful.
Good morning. Nissa, thank you for being here. I think you've probably had an opportunity to look at the bill and consider what we're doing, especially with related to store and forward, but then also on the little working group that would be put together.
Yes, thank you so much for the opportunity to provide testimony this morning regarding draft 1.1, an act relating to healthcare services delivered by telehealth and telephone. I do have my colleague and medical director for Vermont Medicaid, Dr. Scott Strenio, on the line, and he will also provide testimony on both Section 1 and Section 2. So with regard to Section 1, it's the coverage of healthcare services delivered by store and forward, and this is based on an original effective date in the underlying legislation of January 1 of 2021. And so DVA's ask is that the effective date in the draft of the bill that would move forward remain January 1st of 2021. The way in which the underlying legislation defines the applicability includes not only the commercial health insurers, but also DVA. And so while the Department of Financial Regulation's emergency rule was able to enact or effect the store and forward coverage for the commercial health insurance plans as of May 1st, and this language would then make that effective date retroactive to the May 1st date. DVA has been planning and implementation consistent with the original January 1st, 2021 date in compliance with the legislation that was passed under H723 by the House, and then within H742, which became Act 91, as part of the emergency response. So just to frame it up, the ask for Medicaid would be that our effective date remains January 1st of 2021, and there are a couple of reasons. As everyone, I believe, is well aware, we have all been very busy responding to the emergency. And just as provider associations have asked the Department of Vermont Health Access and the Agency of Human Services to waive or postpone requirements to support an effective response, our focus has been on implementing the flexibilities and waivers required to support an effective response. And so the department, like other organizations throughout Vermont, has also experienced staffing pressures due to the impact of COVID-19. And so our focus in the last 8 weeks has really been focused on that emergency response. We want to ensure that we design a very thoughtful implementation for the coverage of store and forward services that incorporates lessons learned actually from our telemedicine policy change, wherein just simply turning on codes and providing reimbursement parity does not necessarily translate into increased utilization. And so although we had a very generous coverage for telemedicine prior to the emergency, and services that were clinically appropriate for delivery through telemedicine and medically necessary were reimbursed at the same reimbursement rate as those services were they to be delivered face-to-face. It took a pandemic to push forward the increase in utilization that we saw. So having the coverage and reimbursement does not necessarily translate to utilization. Along those lines, we want to ensure that the design for implementing store and forward coverage includes a value-based model, recognizing that there's a lot of uncertainty right now around the state's budget as a whole, and also how that will apply to and impact the department and agency. And we also want to ensure that the implementation incorporates consideration for access to care and how Vermont Medicaid members and their providers could have increased access to specialists, particularly for those specialties where we know wait times may be longer. And so as an example, in the testimony that you heard related to S-128 earlier this week, there was an indication that for some specialties, wait times can be in excess of 6 months. And so I think there's the ability as we move forward to ensure that the implementation for our coverage of store and forward incorporates key components of improving access to specialty care, keeping more people treated in primary care settings, and reducing unnecessary travel, lost work time, and duplicative tests and procedures. And so our plan moving forward is to engage with our Clinical Utilization Review Board, which will have a meeting later this month. This particular board was established in statute under Act 146 in 2010, and its responsibilities include examining existing medical services, emerging technologies, and relevant evidence-based clinical practice guidelines, and it's comprised of 10 members who are MDs, NDs. There's also DMD, and before a vacancy, there was also an allied health professional. And so we would really like to engage with this board to develop that approach moving forward. Initial conversations have actually happened with a Connecticut company that testimony was provided on, I believe, by Gifford Medicine prior to the emergency, and really looking at how we can use existing technology to enhance access to care and ensuring that people are treated when appropriate in the primary care setting. So that's section 1, and I know that my colleague, Dr. Strenio, has a perspective to provide on that, as he was actually engaged in those conversations and acts as the state's liaison to the Clinical Utilization Review Board. Do you want me to stop there and turn it to him, or do you want me to tackle section 2?
Why don't we hear everything around section 1, so it's all in one little file in our heads? Be helpful.
Perfect.
And another question I would have is it possible that we can get your testimony, at least an outline of what you're saying, in writing, so that we can have that available?
It is absolutely, for both Dr. Strenio and for myself.
Terrific. Thank you. Okay, good.
Dr. Strenio, do I have you on the line as well?
Yeah, so good morning, and a lot of familiar faces. It's good to see you and that you're healthy. I'm a big fan of Store and Forward. I think it's great. We've been talking to different organizations across the country about this platform. And I think it really is the wave of the future. But as Nissa said, there are some nuances here. And I think that we only have to look at how electronic medical records, how that went to understand that it really makes sense to try to get everyone on the same page at the get-go. You don't want to have 500 different platforms if you can avoid it, or 500 different ways of doing store forward. You want the payers to be on the same page, which it's clear that you all are working diligently on making that happen. And I think it is going to happen, but it does take some thoughtfulness. And, you know, to Nissa's point about our curb, the thing is that we have such a diverse, we worked really hard at getting a diverse group of providers on that board so that things can be looked at different perspectives. And there are some nuances, you know, that you just can't anticipate. Now, look, we're never going to get it right no matter how much time we take. There's going to be things that we're going to learn as we go forward, and that's how it should be. But at the same time, if we have the chance and the time to look at data, to see with everything that's been going on, this is an amazing opportunity for us to actually take a look at how telemedicine and or telephonic medical services, how effective was it? Were there some conditions that actually turned out better because of telemedicine or telephonic, and were there conditions that it actually did not do so? So I think that it makes sense for us to take the time, at least some time, to take a look at that. I think if we're able to do that, it will be, you know, like they say, measure twice, cut once. So that I'm happy to take questions.
All right, thank you. I think, shall we stop here and have questions for both Nissa and Dr. Strenio regarding section 1 on store and forward, because I think the next section is different from that section. Is there a question? I need a question. I have a question of clarification. Clarification is that currently, as of May 1st and then stretching back to March 13th, store and forward is covered under Medicaid through DIVA and our quality health plan.
So we do cover store and forward currently in accordance with the statute for teleophthalmology and teledermatology. And in addition, we did for the emergency, so backdated to the March 13th plan, we also turned on the coverage for asynchronous transmission that allows a remote evaluation of a recorded image under that G2010 code.
Okay, and so the issue that we're hearing about now is to clarify the code or the codes that you would be using going forward, to store and forward for asynchronous utilization access. So you would be looking at some code differential, different codes for different types of store and forward. Is that accurate? Is that what I'm hearing? That would be one question you'd be clarifying.
So the legislation that was passed under H742 has a broad expansion of coverage for store and forward. And so we would be looking at expanding beyond the 2 specialties that we currently have opened up through the fee-for-service model. The question that we are evaluating right now is whether there's an opportunity to do that through a value-based payment model.
Okay, so the work that you would be doing after the emergency and before January 21 would be looking at a value-based model. So there's some accountability on the part of the provider in quality analysis. That would be one. Number 2, then you'd also be looking at a differential payment process. Is that accurate or inaccurate?
So I don't think that we have the answer to that currently.
Okay. All right. Now, so if there were a continuation of the current store and forward coverage for through DEVA, and we don't even know when the emergency is ending, first of all, right? Do we know that? Do we have any inkling of that? No. Suppose the emergency were to end July 15th, then how much, what would be the financial burden placed on the state for coverage of store and forward based on what you're seeing currently? Do you have you done any data analysis of that, which would inform the decision to move to 2021?
Last week, actually, the Department of Financial Regulation asked if we could pull together data looking at utilization surrounding store and forward, and so we have put in that data request.
And can we get that as well, please? That would be helpful.
Yes, we
Okay.
can absolutely follow up with those findings.
Okay, that would be good. Because it sounds like there's certainly work that needs to be done, but the question is how much of a cost savings are we looking at if we continue this while you're working on changes going forward? So that would be a question that would arise on our minds as we've been looking at store and forward in section 1. All right, questions from committee members. Representative Lippert, why don't you go ahead? I think you're muted, Representative.
Correct. So to be honest, I'm a little confused because, and I thank Senator Lyons for asking her clarifying questions, because I thought I thought store and forward had actually begun for Vermont Medicaid broadly. Am I correct on that? Again, just to clarify what Senator Lyons said, that this is store and forward is actually currently being implemented and reimbursed broadly, not just for ophthalmology and dermatology. Is that correct, Nisa?
Not by Vermont Medicaid.
Not by Vermont Medicaid.
I think we need
So
to go ahead.
The underlying legislation in the emergency bill was specific to the Department of Financial Regulation emergency rulemaking, which indicated 2 different components: the coverage by commercial health insurers for the G2010, and then the coverage broadly for store and forward, if I am recalling correctly, but I would defer to Legislative Council.
I was just going to throw a line out to Legislative Council. Jen, can you comment on that, please?
Yes, so the language that you passed in Act 91 that had an effective date of January 1st, 2021, changed from the prior state of the law, or current/prior state, that allowed but did not require a health insurance plan, including Medicaid, to reimburse for teleophthalmology or teledermatology provided by store and forward means. So Nissa said Medicaid has been doing that all along. But then the requirement to reimburse for healthcare services and dental services delivered by store and forward means more generally is the one that has the effective date in Act 91 of January 1st, 2021. But then you also gave DFR emergency rulemaking authority to require coverage for store and forward and other things for private insurance plans earlier than that. And so DFR's rule had that coverage starting for most things on May 1st, 2020, and potentially the one code earlier than that, but does not apply to Medicaid. So there's nothing in what you passed in Act 91 that requires Medicaid to cover all store and forward until January 1st, 2021. The bill that you are looking at, the way it's currently drafted, would move up that date for both private insurance and Medicaid and backdate it to May 1st. And so you're hearing DEVA ask, I think at least for Medicaid, for that not to apply until January 1st.
Yes, okay. Well, then I need to say that I was under the misunderstanding that, of course, DFR can't direct Medicaid to implement, but when DFR through the emergency bulletin, emergency rule, directed the commercial carriers to begin covering store and forward during the governor's emergency declaration, I misunderstood that DEVA was in fact that Vermont Medicaid had actually also implemented that. And that is a misunderstanding on my part. And I think when I was listening to your questioning, Ginny, I think maybe I'm not the only one who misunderstood that. I'm really quite surprised to hear that. And I think there was maybe a broader misunderstanding that DEVA had in fact moved forward with store and forward as well.
I think, Bill, that you're accurate in that. I think in our conversations, we probably heard that Medicaid was doing some fairly broad emergency rulemaking, including this one. And but that has not happened. So you're right. So now
I do think you heard from DEVA that they were covering one code, the
Yep.
code G2010, which is remote evaluation of recorded video or image. I don't know how broad or narrow in the world of store and forward coverage of that code is.
Well, okay, so then help us out, because then I did not misunderstand completely that DEVA is in fact doing store and forward
Yes.
under that code. Is that correct, Nisa?
That is correct. And we do have data
And I-
about utilization for both March and April.
I'm sorry, say again.
We do have data that we shared during our last testimony that provides the data for that code as part of the brief communications packages for utilization for the last couple of months.
So
I'm just going to say that I find this testimony quite confusing in that I heard a rationale for, now, first, let me back up and say, I deeply appreciate everything that DEVA has been involved in. And so the one compelling argument, Nisa, I'm going to say, the compelling argument is that you all have been doing extraordinary work in this time. That I find compelling. What I don't find compelling is the other arguments. Because it's the same arguments that the commercial carriers said we can't possibly do this in the short period of time. It would take, it's too much to stand it up, and we don't know what the impact is, et cetera, et cetera. So I'm confused, quite frankly, right now as to, I really want to understand that, in fact, that code, and I understand the difference between fee for service and value based, but that's a whole separate issue. Seems to me. I mean, we are all interested in moving to value-based, but that's not the issue at hand. The issue at hand, I think, is Vermont Medicaid currently providing store and forward under the fee-for-service during this state of emergency? And if you are, then I'm really frankly confused as to why we would not continue to do that, and during the state of emergency, which could last until November, or it could last for some significant period of time. And then the argument we've heard from DFR and the carriers is, why would we undo what we're doing and then try to do it again as of January? So I'm really confused.
Representative Lippert, we hear what you're saying. I think these are the kind of thoughts that are going through our minds, and we might want to put forward during our discussion.
Frankly, I really would like clarification from Vermont Medicaid, and I say this with deep appreciation for all the work you're doing, but frankly, the testimony this morning I find quite confusing.
So let me ask a question that may help, and I'm not sure it will, and I know Representative Houghton has a question as well. The code that you currently, it's a 2010 code that's currently in place during the emergency that allows for visual store and forward, right?
Remote evaluation of a recorded image or video. Yes,
Right.
correct.
And so are you suggesting that not be continued Or are you suggesting that that one code can continue?
That coverage will continue during the emergency, and we are actually looking at the triage codes potentially continuing thereafter.
Well, okay, so the question is, so you're suggesting that that code end with the end of emergency and not be covered until 2021?
The way that we released the policy, we did tie it to the state of emergency. We have
Okay.
not made the determination to end it when the state of emergency ends.
Okay, and then you're talking about the triage codes.
The G2010, that remote evaluation is one of those triage codes, yes, that we turned on for the emergency, and we're seeing utilization. People are starting to really use those.
Okay, so then the issue for you administratively is to determine whether or not to allow the G2010 to continue until 2021, or to end it with the end of the emergency and then have it come back after you've had an opportunity for your task force or your working group to provide evaluation for a value-based model, and it would include the G2010 as well as perhaps other Store and Forward.
So under the value-based, we're looking at the e-consults specifically. So those are those interprofessional consultations, and those are where we're looking at the value-based component. So right now, that is what we do not have turned on for fee-for-service broadly, where we're connecting that originating physician, who's typically in a primary care setting, to the consulting physician, who's typically a specialist.
Okay, so I've got Representative Houghton and Representative Rogers each with questions. So why don't we let them to ask questions? Bill, is that okay with you now?
Yeah,
Okay.
I guess the one question I would still have, and I hope Nisa could answer it along the way, is was there an active decision to not activate further the Store and Forward face-to-face, or I'm not going to say it right.
Intra practitioner
Yeah,
consult.
I really, yeah, I'll stop because I think frankly, there was a misunderstanding. I think there was a broad understanding that DVHA had in fact moved forward with Store and Forward, as had the commercial carriers. And I'm being surprised to hear that that's not the case.
Okay, so let's let Representative Houghton, you have a question?
Thank you. Actually, Senator, you asked many of mine, but I want to just clarify one
I'm sorry,
thing.
I apologize.
Oh, no, I'm glad you did. You said it much more eloquently than I would have. So I just want to confirm, Nissa, in language I can understand. Currently, DVHA is reimbursing when a patient sends a doctor an image offline, correct?
Under the G2010 code, yes, that's correct.
Okay, whatever the code is.
Yeah,
You are not covering the dermatologist who's sending the primary care provider who's sending an image to a dermatologist.
So that is one where it is reimbursable.
Okay,
the
sorry, bad. I know,
teledermatology.
sorry, bad because dermatology, but from provider
Yeah.
to provider, right? Okay, so
Outside of the two indicated, yes.
and I apologize if I didn't catch this in your testimony, but what do you think you need to do, or what would you do in order to determine getting it up January 1st versus May 1st? I mean, why, if the carriers can do it, why can't Medicaid do it?
Exactly.
So part of our request for the January 1st, 2021 date was allow us to bring the policy change to our Medicaid and Exchange Advisory Committee, who has a responsibility in policy development and program administration. Also to engage the Clinical Utilization Review Board, given their responsibilities, and then coordinate how we implement it with our other activities, including coordination with the Accountable Care Organization. And because we had to cancel established meetings for the month of March and just resumed with the Medicaid and Exchange Advisory Committee meeting, which was actually focused on consumer feedback regarding the use of telemedicine and feedback we were receiving from Medicaid members in April, the first opportunity to bring it to the group would be June's meeting.
So and sorry, and then I'm done, Senator. So if it's meeting in June, could you do it sooner than January 1st? And you can answer.
I do think there's a potential we could do it sooner than January 1st if everything continues on the path we know it to be on now.
Okay, thank you.
All right, Representative Rogers, you have a question.
Yeah, I think I'm getting more clarity on this. I just am trying to make sure I'm understanding within the umbrella of Store and Forward what is and isn't currently covered by Medicaid right now during the state of emergency. So it sounds like the G2010, the code that you're currently using, is tied specifically to either the image or video originates from the patient, or it's between a primary care provider and the two dermatology or the two specific areas that are called out in current law. Is that accurate?
The G2010 is the patient-initiated contact with the provider. And so the coverage for Store and Forward for teleophthalmology and teledermatology was where the existing coverage for Store and Forward was limited under Medicaid. What we would be looking to do is broaden that out in accordance with the legislation that was originally indicated for more specialties than just those two.
Okay, so once that is broadened out to more specialties than just ophthalmology and dermatology, does that then complete the expansion to cover all of Store and Forward, or are there other areas of Store and Forward separate than both of those two things that also would need to be expanded out?
I do not think there are any more expansions that would be needed.
Okay, Representative Cordes.
Do the existing dermatology and ophthalmology, the reimbursement practices, those are value-based?
No, those are currently fee-for-service.
So you would be looking to move those into value-based as well?
Ideally, yes.
Thank you.
Other questions? Okay, so I think we're starting to get it, and we appreciate your taking time to educate us a little bit. But so the question about value-based, it seems to me then you're looking to work within the ACO model. But if a practitioner is not a member of the ACO, are you going to move to value-based regardless of who the practitioner is? Or will there still be some outstanding fee-for-service payments as you're looking forward to developing this, what you're talking about?
So I think we're looking at coordination with the ACO program, but there could be a contractual route where we could engage with a firm like the ComforMed firm in Connecticut to be able to provide a value-based option for broad coverage of Store and Forward. I think the reality is that there will be some fee-for-service that still continues.
Okay. And do you know what, have you cost out what the contract will require? What the financial?
That will be the next step after the Clinical Utilization Review Board meeting and review in May, is to be able to create a fiscal estimate for what that would cost and the budgetary impact for 2021.
So as you're doing that financial assessment, are you then, you're getting a picture for what it would cost to expand Store and Forward, in the current fee-for-service environment, right? So you're going to have that information in May from the Clinical Review Board and possibly from the ACO. And so I'm leaning toward Representative Lippard's question of why this can't happen as, as the emergency is going on. And so maybe there's some language we can put in place that would facilitate some expeditious decision-making, even though I know how busy you are. I shouldn't have said that. I can't, it's a huge burden and we understand that. But just some thoughts then about the work that might go on while the emergency is still in place and having some additional store and forward. I see Dr. Strenio, you're shaking your head somewhat, but maybe you could, between the two of you could respond to my thinking there. And then I know Representative Page has a question. But Dr. Strenio or Nissen?
Oh, sorry. So I apologize if I made this more confusing than it ought to be. I think the thing is expanding store and forward for other specialties. It's a little bit different because every specialty is going to use asynchronous in a different manner. And what I wanted to do to make sure of is that we coordinate with the payers. I'm not sure how they figured this out or how they're going forward with it, but I want to try to make sure that we're all on the same page with that. I do want to bring along our CURB membership and make sure that they have some input into this, and then to look at this value-based model. I think is important. I think Nissa and I would agree that we would do everything we can to expedite and not to redo something if we can get it right, as however it's being used today. So I just wanted to like I said, I'm a big fan of that. I think we're all a big fan of it. So there you have it.
Okay, thank you. Representative Page?
Yes, Chair. I'm curious, is the review for the expansion of store and forward, is it going to be cost prohibitive to do this? And if not, like the chairs have already said, why can't we just continue the coverage?
So we can continue the coverage. The question from our perspective is the expansion requirement. So the coverage for store and forward for the two specialties that we're already covering through fee-for-service, that will continue. There's no plan to discontinue that coverage. It's also very likely that the new coverage that we provided for the remote evaluation code will also continue post-emergency, because we're seeing providers begin to use those triage codes to determine whether patients should come into the office or require an additional service, or whether it's not something. And I think when we're looking at a cost-effective approach that encourages access to care as well, those could potentially continue to be extremely beneficial for providers to use and be able to be reimbursed for brief communication services where that coverage and reimbursement wasn't in place before. The question around the expansion to additional specialty types has been the issue that we have been working through to ensure that we implement it in a way that when we open it up beyond teleophthalmology and teledermatology, that we are designing the expansion in a way that we see the utilization and that we are reimbursing for interprofessional consultations or those e-consults in a way that's both predictable for our budget, but also provides reimbursement for providers who are offering those services.
So this expansion of these specialty types, can't you just review it? Why are we going through this discussion? You know, if your coverage, I'll just leave it there.
Okay, so Representative Page, thank you. I think there's a lot of discussion that's going to happen after we've heard all the testimony. And we do appreciate the work that's going on and the thought that's going into the expansion. All right. Why don't we move on to section 2 with Diva, and knowing that DFR is also waiting to testify on the little bill that we have in front of us. Little bill getting bigger and bigger every minute.
Yeah, so section 2 is the section that applies to coverage of healthcare services delivered by telephone and establishes the working group that DFR would convene and facilitate. And the department's ask around this particular section is just to remind everyone who would be reviewing this language that Vermont Medicaid models its policies after CMS. And so the inclusion of language around as permitted by federal regulations or guidance will likely be part of the recommendation that we would advocate for in participating in this established work group. To date, CMS has been very clear in their expansion of audio-only services and reimbursement associated with those audio-only services, that it is tied to the declared public health emergency. And so unless the federal guidance or regulation changes, the expansion of CMS's indicated coverage for audio only will end when the declared public health emergency ends. And so we want to ensure that we are obviously producing recommendations that are in alignment with federal regulations and guidance. To date, it took a while for CMS to issue their broader list of certain services that they would approve for delivery by audio-only means, and also to increase the reimbursement rates for those services, inclusive of the evaluation and management services that are indicated for delivery by audio only. And so we previously, before the emergency, also covered those audio-only services. It was a request of the department in designing the temporary audio-only coverage that rather than ask providers to use those audio-only evaluation and management codes, we provide an opportunity during their emergency for providers to deliver care as they normally would when it was clinically appropriate for audio-only delivery, and reimburse at the same rate as if the service were being delivered in person or face-to-face. So CMS, who was slower to release their approved list than we were in responding to the emergency, which is not surprising by any means, has a much more narrow list of services for which they have approved audio-only delivery. And it's really focused on those evaluation and management service codes, and then also for counseling and patient education. And I think this is where I would turn it over to Dr. Strenio, because there are a couple of considerations that the working group will need to really critically think through. One relates to consumer choice for how they receive their healthcare services. And so for those of you who are well acquainted with the language that was in H723 that was then incorporated into H742, there's a specific requirement through the informed consent process for Vermonters to be able to decline their service delivery through store and forward, as an example, and be able to request their service delivery through telemedicine or through face-to-face. And from feedback that we've received from Medicaid members, I think there would be a request to also look at potentially including that within the informed consent as applicable for service delivery through telemedicine, so that people know that they have the option to request their healthcare service delivery through another means. So that's one component. And then there are other elements that really look at balancing access to care during an emergency as compared to ensuring adherence to standards of care when we're not in an emergency. And so Dr. Strenio, would you be willing to speak to that component?
Sure. So, there again, this is a little bit, well, it's vastly new territory. I think that no one would say that the standard of care right now is the same for telephonic compared to telemedicine or an in-person visit. Actually being able to be there in person with your patient, or at least by telemedicine, is still, I think, widely considered the standard of care. And I think we need to be thoughtful about that. There may be things that telephonic can work well, although there are concerns there about whether or not doctors making a decision based on accurate information, exactly who might be on the other end of that phone, that the decision making could be based on flawed data that the doctor is using. And as much as access in an emergency, I think, has to take precedence, and there's a lot of good reasons for that. At the same time, to not to reinforce the standard of care to see somebody in person is, I think, would be. Would it provide, and these are just thoughts that I think we have to think about, would it provide a disincentive for a patient to actually come in and see their doctor? And there is so much that happens way beyond just a conversation with a patient when you're trying to factor in clinical decision making. So and again, to my earlier point, this is a great opportunity for us to gather data on the effectiveness of these different modes of healthcare delivery. And I think we will learn a lot going forward as to what is, there may be some things that are best served in these different modalities. But it does concern me that telephone only is something we just really have to be very thoughtful on.
Okay, thank you for your comments. I have a couple of comments, and then I think we should move on to DFR. Personally, I think that the practitioner's decision-making regarding the patient is key in this. So if a practitioner thinks that the patient should be seen by telephone, I don't want to step in the way of that. And in particular, with any emerging changes around COVID during the fall and next winter, there are a lot of patients who will not want to go see their doctor. And there are a lot of doctors who don't want to see those patients. So I think, so there's a lot embedded in what you have said. I do know that we're hearing from practitioners about the other two codes for store and forward. What is it, the 99-451 and 452, that they could be turned on. And we don't have time to get into that conversation, but we will perhaps have to come back to it. So I think you hear the committee questions and our frustration about wanting to move forward, but we understand the pressures that are going on. So I think that we should turn to Sebastian Arduengo briefly. Sebastian, I'm hoping you're there. And before I do that, just Nissa and Dr. Strenio, both of you, thank you very much for the time they've taken. And if you could get back to us about just turning on the 99-451, 452, I don't know the implications of that, but certainly that would be helpful. And then your comments on the working group are very helpful. So thank you.
Thank you.
Thank you.
All right. So we'll turn it over to Sebastian. Thank you for being here. There you
Hi,
are.
good-
You keep moving around my screen. I keep losing you. Now we got you. Thanks for being here.
Yes, thank you. Sebastian Arduengo, Department of Financial Regulation. As to section 2 of draft 1.1, we view the working group as a continuation of the work the department has already been doing in holding weekly conference calls with stakeholders across the payer and provider communities, along with the healthcare advocate, with respect to COVID-19 issues. So this working group would just be another item on our agenda every week. And we have already started discussing what the future of audio only services will look like after the COVID emergency ends. And I think to the points that Nisa and Scott were making, there are a lot of nuanced issues that we'll need to work through. But the thing I wanted to bring to your attention is that, like Medicaid, our authority for emergency rules under Act 91 is limited to the duration of the state of emergency. So we would like some continuing authority to keep the emergency rules in place, especially with respect to COVID treatment and audio only telephone and telehealth for some time after the state of emergency ends. That way we can either provide an off-ramp to providers and payers where we can wind these things down in an orderly manner, or have some time for either us by rule or you by statute to implement a permanent solution based on the working group's recommendations.
Okay. Is that it?
That is it.
All right. Any questions for Sebastian? I think we understood that. That was helpful. Representative Rogers. Representative Rogers.
Thanks. I just have a quick question. I'm wondering, one of the advantages of telephonic medicine being that it's available to providers in areas where they don't have the internet access to use telemedicine. And I'm wondering if the department would have a position on adding in language about outreach to providers in areas that are underserved with broadband in the state to receive feedback from them.
We don't have a position on inclusion of that language, but that's something that we've been we would be happy to do. I think as time has gone on, we've included more and more people on our conference calls, and it's been great to have all of the different perspectives to inform our decision making.
Thanks.
Okay. Thank you. Good question. I think we're all good unless there's another hand up. Representative Page.
I guess my comment is I get a little frustrated with these different working groups. It just seems to me, and I'm coming back from my background, it's like we have to make a decision through a working group, when it's too bad there can't be some individual that can't just make a decision, based upon all the data that they've seen and all their experiences. It just seems like these things take forever long. We have to have a working group for everything. And I just don't understand why somebody just can't make a decision and just do it.
So
You know?
could I jump in and say, Representative Page, does your background include an organization that has a command structure by any chance?
Absolutely.
Just wanted to clarify that for anybody who doesn't know.
We
No,
got it. It's very clear.
it just gets a little frustrating for me that nothing is ever simple, you know, and I'll just leave it at that.
Oh, so, you know, welcome to democracy. Democracy was never meant to be simple. Senator McCormick.
I'll send you a poem by Grace Paley in which she refers to the legislative process or the committee process as analogous to watching granite erode.
Thank you. I look forward to receiving it.
Okay.
And then you can appoint a group to read it together and think about what it means.
Okay, thank you. This is a good note to move on to the next agenda item that we have. And Sebastian, thank you for being here. He's turned his page off already. Okay, and we're moving on to Sarah Clark, who has been on another call. And thank you, Sarah, for being patient, but also for being here to give us the update on the budget adjustment. And do we have something from you on our webpage, I believe?
Yes, that's correct. Good morning, everyone. I sent over earlier this morning 2 documents. One is our very detailed ups and downs that we do through our normal budget cycle. So the committee is probably familiar with those documents from kind of when we come in for any sort of regular budget testimony. It's pretty detailed. So I think for today, what I want to focus on is there's a more summary level document for the budget adjustment supplement number 2. And so we can walk through that. If it's helpful, I can share my screen and walk you through in that manner. Or if folks have access to it at your home offices, then you can kind of follow along.
I think if you put it up on your screen, I have it on my little iPad and it's going to be squinting to really see it effectively. So if you put it up on your screen, I think that's helpful.
Okay.
We'll all be on the same page.
Perfect. Okay, great. Can everybody see my screen?
Yep.
Awesome.
It's also tiny.
It is a little tiny, so I'll try to see what I can do to zoom in for folks. Great, so let me kind of start off by saying that the budget adjustment supplement for state fiscal year 20 does not include any action related to the proposed uses of the coronavirus relief fund. If you recall, that's the $1.25 billion that has come direct to the state of Vermont from the US Treasury. Expenditures from the coronavirus relief fund are being handled primarily through the Joint Fiscal Committee process in a negotiation with the legislature. On Monday, the Joint Fiscal Committee approved expenditures, the proposed expenditures from the administration of the Coronavirus Relief Fund. For the Agency of Human Services, that reflected roughly $116 million of spending. So today, first I wanted to talk to you about the budget adjustment, which again doesn't include the Coronavirus Relief Fund expenditures, but it includes other spending related to COVID. And so I'm prepared to walk you through at a high level what that budget adjustment is. And then if time allows for me, we can talk a little bit more about the Coronavirus Relief Fund. I know both Representative Lippert and Senator Westman are on the Joint Fiscal Committee, and so they are familiar with that.
And Senator Cummings, who's chairing it.
Sorry.
Yep, she's here.
I can't see everybody on my
No,
screen
it's
now that I'm
okay. It's
sharing it.
okay. We get it.
And I also know that after my testimony today, you have the commissioners from DMH and DEVA and then DCF. And so they'll also, I think you'll have some time today to dig into some other areas. So with that said, the budget adjustment supplement for the Agency of Human Services essentially reflects a $37.7 million decrease in spending authority from the budget adjustment that was passed and signed by the governor in March. That's primarily attributed to one thing, which is the enhanced FMAP, the 6.2% bump that we received related to the Medicaid program. If you recall, I think I was in your joint committees maybe a month ago talking about some of the federal fund sources that are available to the Agency of Human Services, and one of those is that 6.2% FMAP bump. That essentially allows us to leverage additional federal dollars for every dollar of Medicaid that we spend. And in this budget adjustment, it translates to $38 million of savings estimated on the general fund. So with that high level overview, I think I'll turn to this spreadsheet and walk you through some of the more specific information in the budget adjustment. So the first line, can you tell when I move my cursor, can you see that? Does it shade things for you? Okay.
Yes.
Perfect. Okay,
yes.
great. So the first line I want to draw your attention to is we are requesting a new appropriation be established at the Agency of Human Services Secretary's Office to serve as the kind of conduit for any potential FEMA reimbursable expenses. The Agency of Human Services established a branch of the State Emergency Operations Center in response to the COVID crisis. This appropriation that reflects $6.1 million of potential spending is associated with the Human Services branch of the State Emergency Operations Center. And so the funds that could potentially flow through here reflect any potential FEMA eligible reimbursement. This estimate of spending reflects a point in time as we were at the Agency of Human Services developing the isolation, housing, and recovering sites, as well as the feeding plan for individuals in those sites. So of this $6.1 million, there is roughly $1.6 million associated with feeding costs of the individuals that are housed in our isolation and recovery housing. In addition, there's roughly the balance of the funds, roughly 4 million plus, is associated with the point in time estimates of establishing those isolation, housing, and recovery sites. So this includes the campground at North Beach that was stood up with RVs. It includes Harbor House, which is a housing program on Shelburne Road in Shelburne, Vermont, as well as the costs of hotels that were stood up and some have now been stood down in response to the COVID crisis, to allow and ensure that there was housing available for individuals as they became either COVID positive or exposed to COVID. So I think it's important with this appropriation to understand it's established to reflect the potential for FEMA reimbursement, but it doesn't necessarily mean we're going to spend these funds or that we will eventually even pursue FEMA funding.
Okay. I don't want to ask, I'm not going to ask a question now. I'm going to save, I think we'll all save our questions until you've completed your testimony. So if folks wouldn't mind writing your questions down and then we'll circle back.
That sounds good. So with that, I'm going to move to the next appropriation, which is the AHS Secretary's Office Global Commitment Appropriation. If the committees recall, this is essentially the mixing bowl of funding for our Medicaid program. It's where we appropriate both the state and federal sources of Medicaid. As I mentioned in my opening comments, you'll see this $43.6 million decrease on the general fund. The bulk of that is the result of the 6.2% FMAP bump that states have been given the opportunity to leverage as a result of the COVID pandemic. In addition, there are some general fund savings associated with additional recoveries into the State Healthcare Resource Fund. So from when we left the budget adjustment and it was signed back in March to now, we've experienced an increase in recoveries, primarily associated with one Suboxone manufacturer. So there's an additional $1.5 million of state healthcare resource funds that we are going to leverage. The reason that we're doing that is all of these general fund savings that you see, 43.6 million, those general fund savings are essentially dropping to the bottom line of the state's finances. As you know, we are experiencing significant general fund revenue shortfalls, both in state fiscal year 20 and projecting out into 21. And so that is part of the kind of closing construct for state fiscal year 20. In addition, in both the general fund and federal fund, you're going to see as we walk through each of the department appropriations, there are some savings associated with the Medicaid program and a decline in claims. We'll talk about that as we roll through the departments, but you see those additional savings attributed both to the general fund line and then here in the federal fund line. The last item I want to talk to you about is this $10 million, which is essentially a placeholder to allow the Agency of Human Services some flexibility as we go through closeout this year. This $10 million would allow us to access, if needed, some of the internal reserves that we maintain at the Agency of Human Services. You may have heard of something called the non-budgeted revenue account, the federal holding account. It is a mechanism that we have at the Agency of Human Services, a balance in it now. And we are proposing, because there's so much unknown and uncertainty around how we're actually going to close the books on June 30th, we wanted to give ourselves the mechanism to be able to access funding that we have available at AHS in case there are any challenges with closing out the Medicaid budget. At this point in time, I can't say to you that I know I have $10 million of pressure within the Medicaid program I'm going to have to cover, but we wanted to make sure that we had all of the tools available as we go into closeout this year. I think I've been through, this will be my 6th closeout at the Agency of Human Services. And I expect it's going to probably be the most challenging of my career. So this will help us with that. Okay, I'm going to move along now to the Department of Vermont Health Access. You'll see in the admin appropriation of DVA, there are some general fund and federal fund savings offset by an increase in essentially what is interdepartmental transfer funds. This has to do with DVA had 4 employees that went to the Department of Labor to help out with the call center, kind of in response, as you know, the Department of Labor has been struggling to kind of come up to speed with some of the pressures and challenges it's faced with unemployment insurance. And so DVA had some employees that were able to help out at that call center. As both of your committees are aware, DVA does run call centers, and so they have some experienced employees in that regard. I'm going to kind of walk the next 2 appropriations at DVA, the Global Commitment Appropriation and the state-only appropriation. You see combined across all fund sources there, you see together almost $12 million of savings. This is attributed to a reduction in claim submissions that we have experienced with the COVID crisis. As you are aware, because of restrictions that have been put on Vermonters and people across the country, folks are not accessing healthcare services in the way that they normally would. As such, we're seeing fewer claims being submitted, which translates into savings on the Medicaid program. And so that's what that $12 million between these 2 appropriations, $7 million in the Global Commitment Appropriation and $4.7 million in the state-only appropriation. That is what you're seeing there. As we move down to the Medicaid non-waiver matched appropriation, you're also seeing some decreased claim submissions, as well as the Children's Health Insurance Program also is able to take advantage of that 6.2% FMAP bump. And so you're seeing those savings baked into this appropriation. One of the things that I want to mention to you, in addition to the decreased claims that we are experiencing in Medicaid, as the committees are aware, in the wake of the COVID crisis, the Agency of Human Services tried to move as quickly as possible to establish financial relief programs to shore up our critical healthcare system. So specifically, the phase 1 of that relief and the funding for this, you're going to see on the Coronavirus Relief Fund side, so through the Joint Fiscal Committee process. But it does relate to the budget adjustment, because another reason why there are some savings that we're seeing is because we're shifting costs from our Medicaid program into the financial relief programs that are funded by the Coronavirus Relief Fund. So specific to Medicaid, there are two things that we stood up. Immediately for the month of April, there was a retainer process whereby healthcare providers could apply for assistance to the Agency of Human Services through an application process with an established methodology to review those requests, and financial relief was granted. The intention was to give immediate cash assistance to providers that were in dire straits. As part of that program, the Agency of Human Services essentially made payments of roughly $4.4 million. That was phase one. Phase two, and phase one was designed to provide a bridge to get providers to phase two. Phase two reflects prospective payments that providers could opt into that would help to stabilize their cash flow for the months of May and June. So we have had providers already opt in for May prospective payments to the tune of about $7.6 million. And I believe providers have until next week to opt into June prospective payments that would provide them some additional financial relief. Again, the funding for this is on the Coronavirus Relief Fund side, the Joint Fiscal Committee. I know I'm saying a lot, so I expect there'll be some questions when I'm finished, but we're getting there, moving through. So now I'm going to move us to the Health Department, to the Alcohol and Drug Abuse Program Appropriation, ADAP. What we're seeing there, you'll see a 1.2 million decline in the Global Commitment Fund. These reflect very similar items to what we talked about for DEVA. It's a decline in claims submitted, as well as moving of expenses through the financial relief processes that have been established to the Coronavirus Relief Fund. So you're going to see in the JFC materials corresponding expenses. Moving to the health, the two items that you're going to see here, you see a $200,000 decline in special fund revenue. This is attributed to the loss of Medicare revenue. As you can expect, the patients, then kind of an inability to accept patients at the Vermont Psychiatric Care Hospital, similar to what we're seeing in other hospitals. So the shortfall in revenue from Medicare. As well as this committee, we talked about it when I gave some testimony on the federal funds. VDH and DMH in collaboration submitted an application for a $2 million grant to SAMHSA. They were successful in that award, and so this reflects the spending authority needed to spend that $2 million at the Department of Mental Health. And so that's DMH. Now we're going to move to the Department for Children and Families. So within the Child Development Division, you're going to see a $4.4 million request for federal spending authority. This is attributed to the Child Care and Development Block Grant. These funds are being used to help support the Child Care Stabilization Program that was stood up by Governor Scott in the immediate wake of the COVID crisis. This 4.4 million represents the 100% federal block grant dollars that come to the Child Development Division. The Child Care Stabilization Program is also supported with coronavirus relief funds as well, that you'll see in the JFC documents. Then the last appropriation that has some changes in the state fiscal year 20 budget adjustment supplement is the Office of Economic Opportunity. This $2.3 million that you see here reflects the ESG Economic Solutions Grant funds that are 100% from the federal government that go to support emergency shelter response. And so these are 100% dollars that are coming to the Department of Children and Families to help support shelter and housing programs. And so we're requesting the spending authority for those programs here. Similar to the Child Care Stabilization Program, you're going to see additional funds to support these efforts on the Coronavirus Relief Fund side of things. So all in all, that is the Agency of Human Services budget adjustment request. Again, it reflects a decrease of spending across all funds of $37.7 million. And let me unshare my screen.
Sarah, as you're talking, I'm looking at the document that is entitled fiscal year 2020 governor's recommended supplemental budget adjustment, but it only has the first table. It doesn't go further than that. Are the rest of those tables at the end of the budget adjustment document? I've read the first one document we have is quite comprehensive, and that's, and the summary that we have from you is simply one table. It
Yes,
doesn't
what I
go.
just walked you through, is that what the summary is? Let me just check my sent email.
We didn't get the Department of Health Substance Use Disorder, or DCF, mental health issues. That none of that is was included in the summary packet.
Huh, I see it in the email that I sent. Oh, maybe I can touch base with Nellie to make sure that you've got all the right materials, if that makes sense.
That would be very helpful, because the other document is much longer and much more inclusive, goes through the whole Agency of Human Services.
It does. The summary document kind of pulls out each of the appropriations that has changes, but I'll make sure that you have the right summary document.
Okay, thank you. That would be terrific. Would you be willing to entertain questions at this point, or do you want to go along further?
No, I'm fine with questions now. And then if time permits, and I didn't send these documents to Nellie, but I could, we could talk a little bit more about the Coronavirus Relief Fund, if that would be helpful for folks.
Yes, it would. It would be very helpful. So I see that I think Representative Houghton, do you have a question? No, okay. That was from earlier, but Representative Chena has a question, and I have a couple of questions. But we'll go to Representative Chena first, unless Representative Lippert wants to dive in. No, okay. Go ahead, Brian.
Yeah, so you might be planning to get into this more, so I'll put it out there, and then if you are, then I'll just wait. One is, there was the line item, I think that might be a good way to refer to it. It was B 300.1, talking about using money for covering expenses for homelessness, for addressing homelessness. That's what it looks like, that line item. So I'm wondering if we could dig into that a little more and learn a little bit about what those expenses, like, what that money went to, the process. For example, like you may not have all the answers to this, but like one question I have around that is, what was the process for choosing who to rent campers from, for example, and why are people now being kicked out of the campers? Because they are, and so I kind of want to dig into the policy behind that spending, and I don't know if we'll have time for that. And then the other question that I have for you to just consider is, you mentioned there's a decrease in spending of approximately 37%, 37.7 or something like that. And I'm curious if there's a way for us to understand who is going to be most impacted by that reduction in spending, like what groups of people or what population. I'm assuming some of it has to do with services just not being available because you can't go places, right now. But I'm wondering if you can get into that some more. So those are my questions.
Sure. Great. So I think you're right about your first question relating to that B.300.1 appropriation. I can't really speak to some of the policy around it. And that you may want to have some members of the State Emergency Operations Center to come in to talk about some of the specific decision-making behind that. But what that appropriation, the intention is that it would capture any of the costs associated with the potentially FEMA allowable isolation housing and recovering programs that were stood up. And so you're correct when you refer to the campground at North Beach. It also would reflect Goddard. If you recall, we had kind of surged to get Goddard online, and then as the crisis evolved, it was determined to perhaps not be the most appropriate decision, and so it kind of morphed into a motel program for The housing that I'm referring to specifically here really has to do with individuals that need housing that are either COVID positive or COVID exposed. It does not reflect the increase in the emergency housing program associated with individuals being homeless that are not necessarily COVID positive or COVID exposed. And so you'll see on the Coronavirus Relief Fund request that was approved by the Joint Fiscal Committee, a roughly $13 million request for CRF funding to handle the especially increased motel voucher program in the wake of the COVID crisis. So I think that's the answer to your first question. And then to the second question, I would say that $37.7 million reduction should not impact Vermonters. The driver of that decrease in overall funding is really the enhanced FMAP, the 6.2% that the state is able to leverage from Medicaid. And so that's just us leveraging more federal dollars and saving state dollars. And so it's not a decrease in services to folks. That answers your questions.
Okay,
Great. Senator Lang,
yeah, go ahead.
Representative Chena, Brian, I might also suggest that in terms of some of the policy decisions around the efforts around homelessness, that we might turn to some of our colleagues on the General Committee in the House, which is, I think, taking a deep dive around issues of homelessness, as well as perhaps our colleagues in the Human Services Committee, where they may very well be involved. But I know that Representative Stevens, as the chair of the General Committee, their committee is very involved in looking at the issues and policy issues around the homelessness response. So just as another resource for us.
Okay. I'd like to continue with a question about the FEMA funds. So those FEMA funds are overseen through the emergency management folks, so Erica Bornman and her group, which is different from, but are there, I guess the question that maybe you can't answer is the communication line between Agency of Human Services and Erica or the emergency management folks. Are there open communication lines? I think that's one of the questions that Representative Chena is asking.
Yes, and so though I'm not a member of the SEOC, I have one of my core team members actively participates from a financial perspective. And so the Human Services branch of the SEOC is part of the incident command structure of the overall SEOC. And so there is direct communication with Director Borneman and the Human Services branch members. And so typically in anything that the Human Services branch is doing is in coordination and collaboration with Erica and her team.
That's helpful. I mean, because the question that I had really relates to having migrant housing when someone needs to be quarantined or isolated on a farm, and there aren't extra places for folks. So knowing that we do have funds but now hearing that the camps are being closed down, and the emergency is ongoing, I think there might be an interest on the part of at least one or both of our committees to follow up on that. Thank you. I have another question. So when the $12 million, for example, approximate, that's been reduced because of claims. Now, is that looked at as an avoided cost, or is it looked at as savings and money still in the account?
In this construct, it's viewed as, I guess I'll say savings, right? Because we're not incurring those costs because, folks just aren't able to access those services. You've got Commissioner Gustafson coming in, I think, right after me. And so it might be a good conversation to have with him in terms of what the expectation may be. Like eventually folks are going to start getting healthcare again. And so we'll be dealing with that.
Yep.
From a financial perspective.
Right. And I was gonna save that for later, but I just wanted to know the basic basic question of how it's counted. That's helpful. Questions from committee members? We've all memorized it. We're all set. This is, no, thank you. This is our really for us on our committees, it's a first go through. I know that there are members of our committee who are deeply embedded in this, particularly Senator Cummings and Senator Westman and Representative Lippert are very much engaged in the process, but it's important for us to be able to understand what's happening. So thank you.
Yeah, of course.
Any other questions? Wow. You are so lucky. That's good.
And just to say, I think budget adjustment is going to come before the House
Right.
tomorrow, I believe.
Oh, that's right. You're voting on this
Yeah.
tomorrow, right?
Yeah, and we've had a caucus
Oh,
presentation.
no wonder you're so silent. Thank you. Okay. All right. I think we're good. We may circle back, but we appreciate your taking the time away from the very important work that you are doing outside of meeting with us. So we thank you very much, Sarah.
Of course, no problem. And if you have any other questions or want some more information about the kind of joint fiscal committee side of things, please just reach out.
We may do that. Thank you.
Thank you, Sarah.
Thank you. Bye-bye.
All right. So we're moving on to, we're still on budget adjustment. And it sounds like the House folks are fully briefed on all of this.
Our briefing was at more or less the high level that Sarah was
Okay.
giving us. We didn't hear from particular departments, but
Okay.
Representative Toll was briefing us for the House Appropriations Committee.
Okay. So why don't we do this? Why don't we move on? I'm looking around my screen to see if Commissioner Squirrel, Commissioner Gustafson, I see Lisa Schilling is here. And Alicia Cooper, don't see yet. We have,
Deputy Commissioner Morning Fox is with us, I think.
oh, yep, he is. Deputy Commissioner Morning Fox, are you interested in going ahead with testimony at this point? Or shall we take a short committee break and wait for the commissioner to come on? What is your preference?
If we could just give Commissioner Squirrel a few minutes,
Okay.
that would be great.
Yeah, we're
Good.
running a little ahead.
Yeah, we are. This is our tradition. What I'm going to suggest is it is 10:39 that we come back. We can turn our screens off and take a break until 10:44. So let's do that. And Deputy Commissioner, we'll be right back with you.
Appreciate it.
Okay, good. So I think mute, and I'm going to stop my video and mute, but we'll be back in 4 minutes. Hello, how are you? Oh, here, man.
Hi, Senator Lyons, how are you?
Senator Lyons.
Good
Nice-
morning.
Nice to
Hi.
see you.
Hey,
to s-
can I
Yes,
ask you a question here? In terms of the schedule, we had Sarah's first. I have actually an 11:15
okay,
life requirement that I have to get to.
okay,
If that is possible to sort of work into this process,
okay.
I appreciate it.
Sarah, what do you think your timing will be on your presentation?
Yeah, it really depends, Senator Lyons, on our actual BAA supplement is pretty small.
Okay,
So that wouldn't take me long. I think if the committee is interested in what the Joint Fiscal Committee has approved for our coronavirus relief estimated expenditures, that's a bigger
right,
discussion. So
okay,
I guess I'll follow your lead in terms of the information that you'd like me to share. Certainly the BAA supplement shouldn't take any longer than 10 minutes. But
okay.
if you want to delve into the other pieces, that will take longer. I'm happy to have Corey go first if that's just easier for him from a time management standpoint.
I guess the what I would suggest is that you go ahead with your presentation on the BAA, and then we move to Diva.
Okay.
If you're able to sort of stick around, at least there may be some questions about joint fiscal.
Sure,
What
I
joint
can do
fiscal is
that.
doing.
No problem.
Does that fit with your schedule, I guess, question?
That's fine for me, Senator Lyons.
Okay, that's great.
Great.
We'll do that. Nellie, how are we doing in terms of folks returning to the world?
It looks like people are coming
I get
back,
that,
so
'cause
we're
it's-
in good shape.
I'm sorry, I didn't hear you. Can we turn on the screen again?
Yes, we can. I'll,
Let's do that.
I'll end the share.
Yeah, then we'll know what we've got. We
Okay.
can get started. Oh,
There we go.
that's better. Oh, here we are. Perfect. Terrific. All right. So I think we're back. Thank you all. It's always good to have a break because then that renews our attention span. So we're going to move through a more detailed look at the budget adjustment, and we've got the Department of Mental Health and DIVA are up first, and we're going to invite Commissioner Squirrel and Deputy Commissioner Morning Fox to present the information on the Budget Adjustment Act. They're also available to talk about what Joint Fiscal has done on the with the federal funds, but we're going to hold that any questioning on that or any presentation on that until after we've heard from DIVA. So that's our schedule. And so Commissioner Squirrel, thank you for being here with us. And why don't you go ahead with your presentation? Should we look at the spreadsheet that we have?
You can look at the spreadsheet and center lines. Thank you. Good morning, everyone. It's great to see you all. Granted on little boxes on my screen, but I certainly hope everyone is doing well. We did supply talking points, which provide a little more detail than the spreadsheet itself. So I'll walk folks through the BAA. We did provide everyone with the talking points related to what we're thinking about in terms of the coronavirus relief funds. And as Senator Lyons mentioned, I can stay on the phone until about 11:30 to answer any follow-up questions that most folks might have related to that. But I'm going to jump into the FY20 BAA supplement. 2 items on that for the Department of Mental Health. The first is related to the Vermont Psychiatric Care Hospital and accounting for lost Medicare revenue due to the COVID crisis. That's a loss of $204,000. This does represent a reduction in what we call our special funds. Due to the low census of hospital patients, we do project that we may experience a decline in Medicare billing and revenue. With the current clients or patients that we are serving, we believe that most of those Medicare benefits have been exhausted, therefore no more billing can occur. It may be possible that we might admit additional Medicare patients in the coming weeks. The likelihood of being able to bill and receive payment by June 30th is very low. So we wanted to make sure that we accounted for that. Also, you'll note on our coronavirus relief request, we have requested that amount to offset the loss in the Medicare revenue. So that is noted there. I guess some good news in terms of our BAA supplement is acknowledging the receipt of an emergency SAMHSA grant, which for the Department of Mental Health represents just over $1 million. So DMH and ADAP jointly applied for a SAMHSA grant. We had just 7 days to complete the application, so kudos to our teams at DMH and ADAP who got that across the finish line very, very quickly. Now more than ever, these grant dollars feel essential. It will contribute to our system of care through the provision of crisis intervention services, mental health and substance use treatment, and other related recovery supports for both children and adults who are impacted by the COVID-19 pandemic. It will allow us to implement and expand some services and, of course, bolster emergency services and mobile response. So I think it's helping us prepare for what I would call the possible surge of mental health needs and needs that we're likely going to see over the next few months to a year. So again, this will just continue to help bolster our efforts. We did kind of break down some of the specific areas of the grant in terms of implementation and execution. The first, of course, is expanding emergency services to those individuals with serious and persistent mental illness. That also includes continuing to be able to leverage the provision of telehealth and more remote ways to provide emergency services to this population, including also more equipment for community mental health agencies and specialized service agencies in terms of tablets, phones, other pieces that will allow us to actually, kind of lean into some of the flexibility that we have related to telehealth. The intention is that these funds will benefit the entire designated agency and specialized service agency network. So we're continuing to work on how we distribute those funds to our partners. Another area that these grant funds will allow us to expand is renovations to existing crisis programs. Some of our crisis programs or the physical buildings themselves do not lend themselves well to trying to isolate and cohort patients. This will allow us to ensure that those buildings are well equipped, given that we're operating in kind of a COVID-19 era. These are some minor renovations that will be needed across the state. And again, all of our crisis programs can continue to provide evidence-based interventions and of course, continue to provide support through telehealth. The third area, which is very exciting, is actually the capacity to use some of these funds to purchase some mobile crisis vans. Again, really helping our emergency services teams get out into the community to see people where they are. In the notes, it does specifically note Rutland. As an update to these talking points, I would just note that we had so many requests in this area from our designated community mental health agencies and SSAs. We've been able to expand this, so actually 7 agencies will have funding to purchase vehicles. So that is something that's in the works. These vans will also be outfitted with gear related to sensory needs, sanitizing agents, and PPE. But again, we're just trying to expand our community outreach and engagement and capacity, and grateful for this grant opportunity to allow us to do that. The fourth area that we're focusing on is mental health peer support services and outreach. This is one of the strengths in our system in Vermont, is having a robust network of peer organizations, our peer support line, peer support outreach, and our supported employment programs. So this funding will benefit the continued provision and expansion of peer-to-peer services that will include some organizations such as Pathways, who are doing some incredible work, who also operate the Warm Line, which has been able to expand its capacity to 24/7 coverage, as well as some of our other peer organizations, such as NAMI and Vermont Psychiatric Survivors. While we were moving very quickly on this grant, I want folks to be assured that there was a lot of outreach with community partners to ensure that their input was taken into consideration as we developed some of these implementation areas. And the last area that we'll be focusing on is certainly just more outreach to individuals. We know across the system that we are seeing less folks presenting in emergency departments, what we would consider perhaps a suppression of need across the system of care. The more that we can outreach to individuals who may be in isolation and may still be vulnerable is important. We also know that I think one of the things we've done so well is in terms of our efforts to house individuals across the state. We are housing more people across the state of Vermont than we ever have. We think there's a direct correlation between our ability to house individuals and not seeing as many individuals presenting in the EDs. So these funds will also allow us to provide more mental health supports to those individuals who might be being housed in some of the hotel units across the state, and really expand that support. So I will stop there. That is the overview of the 2 items on our FY20 BAA.
All right. You know what? Knowing that Commissioner Gustafson needs to leave by 11:15, I'm going to ask that everyone hold their questions with apologies to you, Commissioner, but I think it makes sense at this point.
Sounds good.
All right, good. So we'll just continue on with the testimony, and Commissioner Gustafson, thank you for being here. And,
Good morning.
I think we have the spreadsheet from you. We don't have any other written testimony. Is that right?
Yep.
Okay.
I also was able to listen to Sarah Clark's testimony.
Okay.
And I think she walked through the different pieces, and obviously the big one, if I'll just dive right in, if that's okay.
Please do.
Obviously the big piece is a decreased utilization. And so, you know, the impact that the shutdown to the healthcare system, but for 2 reasons, really, obviously patient safety, but you know, the original stop was to keep hospital bed space available should our surge require a lot of inpatient services for people dealing with COVID. And so we are now obviously in a measured restart, but even that, not positive that means everything's back to normal. I think we all sort of had our different anecdotal experiences. There's hearings we've had even staff members that the thought that the childcare centers might reopen, there isn't, you know, a rush to get their kids back into those environments. So I think the healthcare system is a little bit of an analogy to that, where just because the opportunity to get your elective procedure is there, doesn't mean people are going to take that opportunity right away. So there'll be probably a slower return to what I think we'd all call a new normal in terms of utilization. So that this is obviously our budget up against what was projected before the COVID-19 outbreak. And you know, the decreases in the budget here of both federal and then of course the state match is reflected on what we're seeing and projecting for till the end of this current fiscal year. Of course, it's the BAA. So I know Sarah walked through the different pieces and there might be questions. So there's a couple of others I'll just quickly note. We did pay out to an ACCS provider, Assistive Community Care Services provider, who before COVID was planning to close. You know, we essentially made a payment to that provider, all state appropriation, $47,000, to make sure that they would stay open during the emergency timing. And so that is one other line item to our budget adjustment. The next is a new uninsured population. So an uninsured population pay for testing. It falls into our budget, but that's CARES Act dollars. And then I think that Sarah already described the change in the match. And the last one is the another one I heard her mention, which was us redeploying staff members to other agencies to assist. You know, when it comes to Medicaid and when it comes to DVA, anything that Medicaid related work gets federal match. Anything that isn't Medicaid related work doesn't get that same sort of federal match. It may get a different kind of federal match, but it certainly doesn't get Medicaid federal match. And when we send staff to work for the Vermont Department of Labor, as in this case, it changes our appropriation. And so those are all the items. I'm sure there are questions, and I'm betting that they aren't necessarily all directly related to the BAA. So I have asked, and I believe you might see them on here. I have asked Lisa Schilling and Alicia Cooper, who Lisa is our financial director, and Alicia Cooper is our payment reform director. And just in case we want to get into any kind of detail related to CRF funding or otherwise. So I will stop there. I guess I didn't say the big numbers, which you already heard, which was a gross reduction from just over 990 million of 12 million down to then a 2020 recommended BA of $978,476,071. More than half of that is of those call them savings or state funds. And so I'll stop there.
Okay, I'm going to save my questions, and Representative Cordes has her hand up. So you're up first.
Thank you. I do have a question about the BAA in regards to the discussion in Senate appropriations about EMS funding, and I wanted to hear what your thoughts were about that. Are you aware of the request for financial assistance to EMS providers and then additional for training for EMTs and paramedics?
I don't know about the training. I do know about basically that I would call virtually every provider group has been in a fiscal, choppy waters with the shutdown of the essentially the economy, people not traveling, people not doing things. the answer is pretty long in terms of what we've done, right? So the EMS providers were highlighted as having the opportunity. I'll start with this high level point that we very early on, when the economy shut down, when we knew we were dealing with the COVID-19 issue or state of emergency, we launched into knowing we had to support the provider groups fiscally. So we produced a multi-tract, meaning that different types of providers might fit into different tracks depending on the relationship of which department they had, depending on if they, I'll just mention a few. We had the DEA and SSA track, we have a hospital track, we have nursing homes and PNMI track, and then kind of in all other providers, which is where the EMS providers fell into. And, we have put those models and programs together, obviously in a very urgent way, and with also sort of a, with continuing evolution to the information that we had. So those multi-tracks there, we also had a phased process. I mentioned that in April, we had an emergency relief. I know Sarah mentioned that too. The second is this phase 2 we're in now, which is a prospective payment where providers don't necessarily have to come and ask for money. We are basically making a calculation of the difference between what they normally provide for services and get paid and what they've actually been providing for services for and getting paid, and therefore getting those dollars out to providers. Starting last Friday, I want to say, was when we pushed the button to push the money out. Should have gotten it earlier this week. There will be a second group of payments to go out as of this Friday, which obviously will hit the bank accounts after that. And so your specific question to EMS is yes, awareness, and they fall into this other providers grouping that we've set up these programs to really assist all healthcare providers in a way that it has a methodology and that is understanding of the fact that each provider group is being affected differently. Some providers have no services provided. Some providers have fewer services providers, and some are running at normal capacity, right? So if you're in a nursing home, there's, you're not exactly, you might not be bringing new people in, but you're not exactly just closing your doors. So, there's a long sort of methodology explanation that is one of the reasons I had Alicia come on, but that really spans our approach to all providers, not just one versus the other.
Okay.
Did you have a second question? I'm sorry if I missed the second question.
I do have a question, but it's for Commissioner Squirrel, so I'll wait.
Okay, that would be good. Representative Durfee.
Thank you. Commissioner, I have I guess this is an accounting question, and I'm looking back at the budget adjustment numbers that we were looking at earlier. Just in terms of the relief funding that is coming into the state, the federal, whether it's CARES or some other source, ultimately all of that will flow through the state budget, and some of that will flow through your department budgets. And is that correct?
I think there's a midpoint in that question that I started thinking about and answering. Did you say all the state dollars that all the dollars that come into the state will flow through the state? Because that's one piece that we could talk about. Were you asking that if all dollars flow through the state?
Essentially, yes. If it'll all be visible somewhere in an appropriation. If it'll all.
I have a question in my head that. Let me say this one quick thing that actually HHS at the federal level has distributed, and you may know this, but I'll just say this because it kind of relates to your question. HHS at the federal level has distributed dollars directly to providers. We have had some participation in giving them information about what, most recently we were asked to provide information about how much each of our providers and their like provider ID numbers, each provider got from us in the last 2 calendar years, I believe it was. I'm not sure if it was fiscal or calendar, but last 2 years. And that is going to be the basis on which they distribute another tranche is the word people are using, of funding out to providers. So there have already been 2 that have gone, I'll simplify this for you, to hospitals or Medicare providers, let's call it. And then there's been another that's gone to rural health providers, and that isn't just hospitals either. And so we don't have a perfect viewpoint into that, and that did not go through us. And there's going to be a third that's being characterized as Medicaid providers that we did provide information into, but we will not be the conduit for those dollars to be delivered. And I think you're asking more about maybe Corona relief funds, which money that did go to the state, and that they do have some stipulations and strings. I'm certainly not an expert on that, but I know that as we were, as I said, when this started, we knew that there would be an impact on our healthcare providers. And as a piece of the administration of the state of Vermont's mechanisms, we at DVHA were able to be that mechanism to respond to the sort of fiscal pressures that providers were experiencing. We originally thought, if we have to pay state-only dollars to make sure that there's access to healthcare, we were ready to do that originally. Probably there's a timeline where we were approaching it with that, and so then we, the last piece of my sort of, our priorities was multi-track phase and resource dependent. As soon as we kind of got word that, one of the uses for the Corona Relief Fund could be this, making our providers able to be there to serve Vermonters who needed medical care when they needed it, then that changed the level of resource dependency we had, and we were able to adjust the program. So there have been some adjustments, but that's one place where those dollars are coming through the state. It isn't necessarily a Medicaid program, by the way. It's really our mechanisms, our MMIS, our connection to the providers that allows us to be that mechanism.
Okay, good. Thank you.
Wait for it there. Representative Lippert, you have a question.
Yes, Commissioner, well, first of all, when we think back, it seems so long ago now, but a lot has happened in a very short period of time. And what DVHA and AHS did to secure providers who were suddenly faced with extraordinary financial pressures is greatly appreciated. I believe you may have provided this previously, but is that document that shows the April payments to medical providers in Vermont and then the subsequent prospective payments, is that document available?
Yeah, we can share that with you at a high level. I mean, we're at, I think, $32 million to go out the door in that for both those. You got it right on the April payment where it was about 4.2 million, but now with the prospective opportunity being available, that it pushes those numbers up pretty quickly, and we'll share that document with you.
Yeah, and that document would indicate which providers received which monies during that period.
Yeah,
April and then May.
yeah. I don't see a reason that's.
I mean, it's public information.
Yeah, exactly.
It's not, yeah. Because I know that some of us early on were receiving frantic pleas and emails from different providers in different parts of the state, some primary care providers who I think some people didn't realize how impacted they would be by the dramatic changes in their practice. And we were referring them to the work that DVHA was doing, as well as AHS generally. And I think it might be useful for us to be able to just see where some of those dollars actually were able to be directed. So if you can provide that, that would be helpful, I believe.
Very
Yep.
good. That's good. Any other questions from other folks? So going back to the $12 million reduction in claims, and then how are those funds being used? Are you going to be holding on to them until elective procedures and other office visits start to catch up?
Well, I think I mean, I think we can't forget that the revenues of the state have dropped considerably. So, you know, really in this case, what I would say is, yeah, for the next, what do we got, about 6 weeks till the end of the fiscal year. Yeah, we're not spending these dollars, but they aren't, I wouldn't necessarily say that we just get to hold on to them. They might not be coming in. I know on our provider tax, we have thankfully had our providers aware that how important those dollars are, but we aren't complete in that area. But I would just say that, you know, we're in for probably some bumpy waters as it pertains to how much money the state has to spend. If you remember last year, it isn't just the healthcare resource fund anymore. The dollars that are available for Medicaid match are part of the general fund now. And so we're in that, we're all in the same boat is how I would say it. And yeah, like I said, we do have this reduction in utilization, but if you offset that or compare that against, you know, the Corona Relief Fund that's going out, the other dollars, there are dollars going out to providers. So I would almost call it more of a, you know, a redistribution of funds. And I would never suggest that everybody's been made whole. That isn't the case, but I think it's more of a, I think I'll use the question that was asked before. It's kind of an accounting thing more than anything, that the services are down. But we have found other ways to get dollars out the door to hopefully preserve access. I'll say, if you're referring to just utilization in general, I think someone in my office recently said, look, if somebody was waiting for a knee surgery, that's going to happen at some point. If they avoided going to the doctor's office because they had, you know, symptoms not necessarily reminding them of what they've been told is certainly possibly a COVID, but they have, you know, a runny nose and they just decided not to seek care, that's probably not going to, there isn't like pent up demand for that. We'll be back to normal. So I don't think I have a great answer for it. We're just going to hold it, or we have any kind of plan for it. It all goes into a bigger, you know, conversation about how do we make the state's budget and actuals match.
So one of the things that we were talking about earlier today was telehealth and telephonic communication, store and forward, and the decisions that you folks have been making at DEVA to hold off on expansion for that. And as you're looking at kind of the balance sheet for what has been expended for telephone and for store and forward, it would seem to me that if that balance sheet could be balanced against what the possible use of some of that $12 million between now and January 21, is that anywhere in the thinking at DEVA? Because I will say right up front that there is a strong interest on the part of both the committees, unless I haven't heard differently, in having a more robust telephone and store and forward between now and January 21. So that's just my, that's the question.
Yeah, so there's a couple parts to that. I think I would again say we really don't know what closeout looks like, and so this isn't it. So how about if I go to the other part first? Because if I talk the money first, it's like the wrong approach. How about if we say that we've been really aggressive on telephonic and telehealth, and I think that, you know, clinically we drew a line on the store and forward. I'm aware that that conversation came up in your earlier testimony. I didn't listen to it, but I can tell you that emails are popping up right now about we're going to go have that conversation. So that's not a problem for us to go and examine. And it certainly not including store and forward was not a financial decision previously. So you know, I think we've shown in various areas that really what we're trying to do is make sure that there's a healthcare system for Vermonters to access when they need it, and that we're doing everything we can. I have said on the money side, especially when it comes to the healthcare system, that there's probably a line that's perfect in terms of meeting the need out there. I don't think we're going to get there. I think that it would be kind of, you know, you'd have to be really silly to say, oh, we're going to perfectly meet that line. So we have made some decisions that I think have gone maybe past the line just a little bit to make sure that we're not missing the mark. And so this falls into that for me. If we look at it and think we can do a little more and do it in a safe way for the individuals that are using the services and protect the providers, then I, you know, we'll examine it. So that's the first question. The second is on the dollars. Again, we just don't know what closeout will look like. And so I wouldn't say, oh, it's going to cost X amount and we'll use this 12 million. That just doesn't, that's not, I don't think that's how the kind of world we're in today, because I don't know how much we will have in the go forward, either in current revenues as a state or in the revenues starting July 1. So I just would refrain from saying, oh, that's a good idea. I just would say, you know, if we think it'll help the Vermonters and we think we can execute it, regardless of our, you know, say there might be clinical concerns, then let's at least during the state of emergency step a little bit past the line and then ask for forgiveness later. So that's been a principle for us so far.
Okay, but do keep the telephone and the store and forward in mind, because
well, the telephone is there.
yeah, okay, good. And the store and forward and whatever codes could be put in place would be helpful. I guess there are a couple other questions. I'm going to go to Nolan first, Nolan Langwheel, and then we'll go back to Representative Lippert. So Nolan.
And Senator Lyons, can I just say,
yes, sir.
I have a child issue I got to deal with. So,
okay.
And I do have, I am married and I do have a wife, but she has her work that is not more important than any of us, but I just couldn't.
Oh, but when you are living
for this
with her, it's equally important to you. So we get that, and we're fully appreciative of the stresses and strains. We see it every single day. And would you like to have someone in your shop take over? You want to listen to Nolan?
No, let's just keep going.
All right, we don't, because we don't want to hold you. So let's keep your schedule in mind as we're asking questions. Go ahead, Nolan.
Mine's more of a comment to sort of kind of jump on the back of what Corey had said about the revenues. If you recall, one of the big pieces of revenue is the provider tax, which is a big chunk, and the majority of it, we're talking $150 million-ish, I believe, or more. Most of it comes from the hospitals, and with hospital patient it's based on net patient revenue. With that being down this year, in the out years, we're going to see a big drop in our provider tax. And hospitals, when they get COVID money directly from the federal government, we can't provider tax on that revenue. So yes, we're seeing a savings of 12 million, but we're going to see a big drop in money that we use to draw Medicaid match. So I just want people to be mindful of that when they see reductions or savings in Medicaid now. In the out years, we're going to have some problems. So I just want people to remember that.
Good, thank you. that is helpful, and it does resonate with what we're hearing from Diva, from the commissioner. Representative Lippert?
I'm going to, understanding the commissioner's time pressures, I'll save my questions for another time.
Okay, we're good with that. This is, I know the budget adjustment is coming up in the House today and or tomorrow, and then that's right, and then we'll be seeing it in the Senate. So this is a good beginning for us, and so thank you. We don't want to hold you any longer.
I'll just say too, if any of the senators or representatives have questions they want to just email over to us, we're happy to answer those as well. We have sent you documents as well. If you haven't seen our documents outlining all the different efforts that have been undertaken kind of across the board, policy-wise, and opportunities for enrollment in the telemedicine and in the provider relief areas, we're happy to share any documentation you need. We've got all of it, including scorecards of where we are, what we're seeing. There's plenty of things for us to talk about, Senator Lyons. We would never get through all of it if we really just went on a walk through the woods. Our enrollments, I'll just say this, our enrollments have not exploded. The enrollments in Medicaid have been, we maybe have 5,000 new enrollees in that neighborhood right now. And the prediction was much higher than that. I think we're expecting maybe a lag to that, as Nolan said, as the economy, the out in the future is when this, we might at DIVA and at Medicaid really be experiencing, well, it's normal, right? As revenues go down, need for social services goes up.
Absolutely. Yes. Thank you. All right. Thank you for for your team, for Lisa and Alicia both, for being here. Because I think what we'll do now is, unless there are questions for the two financial experts from DIVA who are here, in addition to the commissioner, we'll move back to Department of Health for a few minutes, and then Senator McCormick, you have your hand up.
Thank you, Madam Chair. On the perverse effect of a loss of revenues to the hospital because of elective care not being given. Is there anything afoot in Washington to change the criteria for Medicaid support, Medicaid payments to hospitals and to other caregivers? Because I mean, this is certainly an unintended consequence of the distancing requirements. And so by honoring distancing requirements, the hospitals, you could count that as an expense to the hospitals, that they're doing the, just like businesses shutting down or being compensated or supposed to be. Is there anything afoot to change, to address that shortfall?
No. No, I mean, honestly, they're really focused on finances, right? How much to distribute to the different areas hardest hit, and right now, right, the conversation, as well as we all know if we watch the news, it's about one is the state and local governments, how they've been hit. So fundamental policy changes to the Medicaid program, those are hard to approach in a non-emergency situation. I mean, just think of the last thing that you had on your mind about the state statute that you wanted to adjust. It's a hard conversation. They're really focused on the emergency.
Well, I'm addressing this as part of the emergency. I'm saying this is part of the emergency.
Yeah.
Okay, yes, and the true up at the end is whenever the end happens, the true up is going to be really part of this whole conversation. So
you know what? That's such a great point. If I could just interject and say that is definitely one of the pieces that we have tried to keep in our mind as we've rolled out any kind of program and effort. It has absolutely been. We know in 18 months' time, federal recovery audit contractors, or whoever you want to call them, will come back and say, now, why did you do this? And so we've tried to keep a really good accounting of our modeling and our decision making. I don't know an accounting of every decision or what the circumstance will be recorded, but we will know what our modeling is and why we decided to apply this factor or add this in or cut something out. So, you know, I know that's not where Senator McCormick's question was going, but your point is so good that.
Well, but that
something we have to pay
it
attention to.
very much linked in with that.
Yeah.
So Representative Cordes, one last question.
I'm still in line for Commissioner Squirrel.
Oh, good. Well, you're first up then when we go back. So Commissioner Gustafson, thank you. And good luck with the childcare issue. We are very sympathetic to what's going on right now. All right.
Take care. Thank you.
You too. Take care.
Thank you.
And thank you, Lisa and Alicia. Thank you both for being here. Appreciate it. Commissioner Squirrel, we're coming back to you, and we have questions for you. So Representative Cordes first, but I do have a question to ask. Might sound like a silly question, but I do have a question. So go ahead, Representative Cordes.
Thank you, Commissioner Squirrel. Really great work on everything, but in particular in getting that SAMHSA grant and working with stakeholders to identify those priority areas. I'm wondering if you have the capacity to connect with the migrant worker and undocumented population. I know that the stressors are definitely impacting them. Some that have lost housing because of farms going out of business. So they definitely have mental health concerns, and happy to follow up at another time, but wanted to run that by you.
Yeah, I think that's such a great point. And certainly, I don't know that has been part of the scope of implementation at this point, but I can certainly go back to our team and talk a little bit more about that, see what the opportunities are. We've also just had some general conversations, particularly for farmers in particular too, given some of the economic stress and strain. So let me think about how we can perhaps weave some conversations into this grant, and perhaps kind of under that heading of some of the outreach that we were looking to do, perhaps kind of insert a focal area on that as well and see what we might be able to work on. And if you have some thinking on that, I might have a member of my team follow up with you if that's okay.
That would be great. I have a couple of people in mind that you could reach out to.
Wonderful, thank you.
Thank
Good.
you.
I was going to say, I think this is a good topic, and it's slightly different from the budget adjustment, but it certainly relates.
Right.
All right, so we have two more questions. Representative Donahue, first Representative Lippert, I apologize, and then Representative Donahue.
Well, I'm just going to pick up on Mari's question, but quite honestly, and again, thank you for pursuing this grant. I think it's really terrific to take advantage of that. I'm glad we had the opportunity. You know, I'm struck. I'm just going to highlight again the particular several particular at-risk groups, and LGBT youth have been identified in non-emergency situations as such a high risk around self-harm, around suicidal ideation, et cetera. And the fact that too many are living in family situations where there's not support, and where the outreach to groups like Outright Vermont and others and their support network has really been what sustained them. And so I would just, again, ask if, in terms of at-risk groups in the mental health community broadly, that to consider whether there's some way that you can also do some outreach, perhaps through Outright Vermont or others, who are in fact trying to continue to sustain support for, which is this important group of young people.
Yeah, that is such a great point. And, you know, we have a couple of different funding streams that we're looking at. We also have the crisis counseling grant that we just received through FEMA that is really focused on outreach. And again, I think to your good point, Representative Lippert, probably our best effort is to work with groups that already connect to those individuals to try to
absolutely.
support their work.
Absolutely.
Because that's the door they want to go through. So I'll just chat with there's some cohesion within the Department of Mental Health in terms of how we're thinking about these grant dollars and implementation. So I can kind of task my team with also making that connection, whether that's within this grant opportunity or the crisis counseling dollars, or just generally that as a group that we need to think about outreach to.
Isolation is such an incredible stressor for this community, and to have the level of isolation that's layered on top of what everyone would experience, even in their non-emergency period. Most young people would, I mean, the level of stress in non-emergency is actually an emergency. And now it's amplified in a huge way.
Yeah, that's exactly right. And we're also thinking about too, in terms of how we're continuing to be creative and flexible in our school-based mental health services as well.
Some of these youth receive their support through schools, and they're not
Exactly
able to access that as well through their peers and their school support through their guidance counselors, so to supportive teachers in an environment. So it's
So that actually is a request that I have heard from members of the Children's Hospital, leaders at the Children's Hospital, to somehow, even during this time, but then post-COVID, to have a continuation of telehealth support, in particular for vulnerable groups. So, and I see Representative Houghton and I are agreeing on that. And so I haven't done anything with that yet, but we certainly, I think it might be helpful for you in particular to reach out to Dr. First at the hospital and Secretary French at AOE to see if there's some links that can be developed. And I don't want to move us too far away from the questions about the BAA, because we also need to hear from DCF, and Commissioner Schatz is here, but Representative Donahue, you have a question.
Yes, thank you. And it relates to the SAMHSA grant in the BAA, which of course is wonderful, but also raises concerns, as any grant opportunities do, in terms of how long it lasts and what's sustainable after it ends, and whether we lose it all. And I guess part of what I'm wondering is if there are job descriptions around the additional outreach or peer support and all that make it really explicit that their COVID response, so that as I'm thinking ahead to loss of revenues for the new fiscal year, where we can't make up for lost revenue in the budget, but if they continue to be really explicit COVID response, that we may be able to, when the SAMHSA grant ends, transfer it to CFR funding, because at least through December, they aren't replacing existing, and yet in the real world, they are in a sense making up other losses. Has there been, when is this money going to expire, and how can we sustain some of it?
Yeah, it's a great point. Shannon, do you know the length of the grant period for the million?
I can get that for you. I want to say it's 16 months, but I want to make sure. Okay. I can get that for you.
So it's, trying to be creative as we all are, if we actually plan to use a lot more of it up front and use it for greater enhancement, and then it runs out sooner, but it then is valid to use CFR funding, then that might be a way to bring more money to play as we lose other revenues.
Yeah, I think that's a smart way to think about it, Representative Donahue, and very strategic. And I think you also see that the team did some strategic thinking too in terms of kind of infrastructure investment.
Yes, all those pieces are terrific because those we keep.
Yes,
And, yeah,
exactly.
it's the other ones that, yeah.
Yeah, that's right.
Okay, this is great. I did have a question. I will ask it, and then whether I get an answer now is probably not important. But we passed a bill out of our committee that had emergency response mental health vans in it. And that bill has gone to, that was a recommend, I think, from the administration. And that bill has gone to the budget or the appropriations committee. It was targeted for Rutland, and now the grant is targeted for Rutland. And then you've said there's 17 other possibility of 17 vans. That's
7.
huge. 7 vans. Well,
7.
that's more doable. I was multiplying that out. I said that grant doesn't cover all that. The question I have is, will this supplant or then obviate the need for the bill we've sent off to appropriations? You don't have to answer that right now if you don't want to or can't. The second question is, I've had a constituent do research on electric vans and a fit up for electric vans that would include all kinds of SSTA type provisions. And those vans through the Heritage Ford, for example, so there's another contact for you, would cost $60,000. And I don't know what your pricing for your vans is, but that's another, you know what, we don't have time to go and do all this stuff, but it's in your hand. I'll give you that note and it might be helpful.
Great, thank you, Senator Lyons. I'm actually not familiar with the bill that had other emergency funding for mobile vans.
Yeah, it wasn't emergency, it was just emergency mental health support.
Okay.
But it was for Rutland. And now when I read through the grant itself, it seemed to me that this might replace the need for that.
I think that might be right. I just want to take a peek at that language first and just confirm that.
Yeah, you better.
Okay.
All right. Okay. Thank you. Not wanting to keep anyone from asking questions. Is there a further question for Commissioner Squirrel? Thank you. Thank you for your work. And we do, Representative Christensen, you have one more question. Here you go. Last one.
The Wyndham Center in, I think, Rockingham, was that hard to staff up after you did the infrastructure improvements down there?
So yeah, that's pivoting into the Coronavirus Relief Fund estimated expenditures. That's kind of separate from the BAA. That is still in process. It's a great question. I would love more time with the joint committees to talk about that work, the progression of that work. We are still in construction mode. So the upfitting of that unit is what is happening now. And then we'll be pivoting more towards staffing. The good news is that the Wyndham Center already has the adequate mental health and medical staff for that unit that are ready to kind of pivot to provide services once the construction is done.
Thank you.
You're welcome.
Okay, thank you. And thank you for the question. And Commissioner, we're going to move on away from mental health and to children and families, but we want to thank you very much for being with us this morning and patient with our time. Thank you.
Thank you very much. Great to see everyone. Please follow up if you have any additional questions.
We will. Take care.
Thanks.
Commissioner Schatz, welcome. And thank you for being here. You're just moving all over my screen. There you are. Why don't we let you go right ahead? Do we have the budget adjustment information spreadsheet? Do we have anything from you separate? It doesn't look like.
We do not. I did not submit anything.
That's fine. That's
fine.
Thank
you. So this is Ken Schatz, Commissioner of the Department for Children and Families. Actually with me here is Sarah Truckle, who's our financial director, as needed, in case you have questions. We did not submit any additional materials because actually, with respect to this supplemental BAA, the requests for DCF really are relatively straightforward. There's because this does not include, as I think you know, the Coronavirus Relief Fund, which has certainly been helpful in numerous ways with respect to our department's activities. The two items that are on our supplemental BAA are monies for our childcare program and our emergency shelter response. So I'll talk about each one of those and then glad to answer any questions that you have. So with respect to childcare, what you see on the supplemental BAA is $4.4 million from the Federal Child Care Development Block Grant, which was additional money from the federal government to support childcare during this pandemic. As many of you know, we have made active efforts to stabilize and support our childcare system and the families who need childcare, both our CCFAP families and private pay families. The stabilization and incentive program that we implemented, the cost of that far exceeds $4.4 million. So we're doing that with a combination of the CRF funds and this $4.4 million. In effect, it's to give you a sense of that, it's approximately $12 million to get through the stabilization and incentive approach. We are also, as you may have heard, the governor announced authorizing childcare programs to reopen as of June 1st. And we are about to start up a new Restart grant program using $6 million to implement that program. So let me sort of stop there and see if there's any questions with respect to the that portion of the supplemental BAA.
I guess any questions, folks? My questions are more about the policies that are going to be in place for childcare reopening and how the link with employees and employers and how that's going to happen. So
I'm glad to sort of briefly respond. Obviously, our Deputy Commissioner Stephen Berbico or our Policy Director Melissa Rigo-Garrett are frankly more knowledgeable than me. But basically, as you may know, with respect to reopening childcare, guidance from the health department was just issued yesterday to clarify how we should go about this approach. And so that's obviously part of the process of educating and supporting our childcare programs and their staff and families to feel comfortable moving back towards reopening Vermont. But I don't know if there were particular questions you had, Senator Lyons, or
no, I think it's not the appropriate time to ask those questions. So I'm going to move. Okay. I'm going to allow us to move ahead. Are there any questions that folks have? Okay. Understanding. Yeah, and understanding. I think that the childcare piece actually in the House is more in the Human Services Committee, and the Senate we have looked at it a little bit. So why don't you go ahead with your next area?
Okay, glad to do that. Yep. So the next item is in the Office of Economic Opportunity portion of our budget, and it's $2.3 million for coming from the Federal Emergency Solutions Grant Program, oftentimes referred to as ESG. This is a program that is typically part of our Housing and Opportunities Grant Program, sometimes referred to as HOP, where we do provide support and funding to shelters and other homeless providers around the state to provide support for our homeless population. Again, as you probably know, we've done a lot of work to support our homeless population during this pandemic. Obviously, they're a very vulnerable population. We have, because shelters are congregate facilities, some of them have closed. The rest have substantially reduced their capacity. We have moved many people into motels. We have waived our normal restrictive emergency housing rules to allow those people to.
You know, it's Commissioner, I think that it's Representative Chena who has his mic on. Maybe you could mute Representative Chena. That's good. Thanks. Okay.
So thank you. So we have made this move, as I was saying, into motels to allow people to be safe during this pandemic. We have asked shelter operators and our other community providers to support people in motels. So not their necessarily normal role, but recognizing that obviously the homeless population does have significant challenges and issues, including mental health, substance abuse, and other real significant obstacles to maintaining sustainable, affordable housing. So we have asked these community providers to support people in these motels. And so the idea of this additional money being available is to grant it out to the community providers to support them as they support people in motels, as they start to think about how to then relocate people from motels into housing. And so it's that whole range of COVID response that we need to implement, and that's what this money is being used for. We have done it on a rolling basis, meaning that recognizing that these providers are acting immediate now and have immediate need for funds. So we have received applications and awarded approximately $900,000 of the 2.3. There's no money that has gone out the door yet, obviously pending this process. But just so you know, that's the extent of interest that very quickly came up in terms of the need for this additional resource to address the needs of the homeless. So I'll stop there. Glad to also answer questions about this request.
There, I'm going to turn my mute off. I think Representative Chena had a question earlier. I'm going to ask that. Senator Ingram, your hand is up, so why don't you go ahead?
Thank you. Thank you, Commissioner Schatz. With regard to emergency shelters and the homeless, how much of the federal funds that are coming in, the CARES, the relief funds, do you have a sense of how those can help us to address our homeless population?
I'm gonna ask Sarah Truckle, who might be able to help me to answer more specifically how much money have we spent with respect to this response overall.
Hi, everyone. So we have in the AA1 process for the coronavirus relief fund, approximately $13.5 million being allocated for general assistance for the motel and temporary housing program to be spent through the end of June. In addition, we also have $1.5 million for emergency shelter and response funds that was also approved on Monday, and then anticipate a housing plan to come.
Great.
Thank you.
One other question. It's a little bit off topic, but if you'll indulge me, I just am wondering how we're doing with the young people who were at Woodside, who've been moved, I guess, a couple of times. I know there were some escapes and some other challenges. What's the department's current plan?
Sure. So that has definitely been a challenging circumstance for us. As you may know, we moved out of Woodside because of the Department of Mental Health's need for that facility, but then they changed their mind. And so we are concerned about, frankly, not making too many transitions, which is hard for both staff and our youth. We are obviously also concerned about the security issues. So we are looking at options as we speak right now to think about, do we continue to maintain a presence in Middlesex, what we're now referring to as the Middlesex Adolescent Program, and bolster the support there, or do we take some other action? The numbers of youth is still relatively low. We have 4 youth in that program. Interestingly enough, the makeup of the youth is frankly different than normal. We are seeing more youth charged as adults who we are sheltering. In addition, we've got a couple of kids who are runaways from other states. So it's a dynamic that we're continuing to look at and analyze as we go forward. There's nothing, to be straightforward about it for the committee as a whole, there's nothing in this supplemental BAA with respect to that program.
One option, actually going back to Woodside, since the Department of Mental Health doesn't want to use that facility.
It's certainly something that we're considering.
I guess the question is, since we're in an emergency and some of this is related to emergency transitions, how many federal dollars are available to support the moving that you've had, the change in staffing and so on? Are there?
So we have, you're correct. We have used approximately a little over $100,000 of the CRF funds to support those moves.
And do you anticipate accessing other dollars for that? It would seem to me that because there's some infrastructure involved, maybe there are FEMA funds for this or not.
I think we're looking at those potential funding sources if we decide to do something that requires expenditures.
Okay. All right. Thank you for that.
Sure.
Other questions from committee members? All right. Is there another section that we need to look at?
No, those are the only 2 that are included in the supplemental BAA.
Okay. It sounds like we have heard everything we need to hear at this point. I know the House is voting on that tomorrow, so then the Senate will be picking it up again. And Commissioner, thank you for your time. If we have additional questions, I would hope that we could either send those over to you or have you come into committee at some point.
Absolutely. Feel free to send questions or let me know if you want more testimony. We'll be glad to provide it.
Terrific. And thank you for all the work that you're doing. It is extremely challenging. And we will probably at some point want to talk with you, at least in the Senate side, about childcare. But we'll come back to that one.
Glad to do so. Thank you very much. Appreciate that.
Thank you. Thank you very much. I think committee, we have reached an end to the morning. We have 5 minutes. We're so good. We're consistent. Let's put it that way. So we're going to call it a day. Good luck tomorrow with your floor session, and we'll see you next time. So everybody take care, and thanks, Bill.
Thank you, everyone. Have a good night.
Yeah, you too. Take care.
Ending live stream.